I'm Doctora Victoria, and this is George.
Today, we are going to talk about diabetic ketoacidosis. For the past 12 weeks, George has been having to drink more fluids and go pee more often. He has lost about 12 pounds and has been having some nausea, abdominal burning, having headaches, and having some acid reflux. He has been a little bit scared and thought he better come to the hospital to see what was going on. Diabetic ketoacidosis can seem a little bit complicated, but it's not so bad when we break it down. Let's look at what some of the underlying problems are. The concern with diabetes is the uptake of glucose, rather the lack of it. This can be because the pancreatic beta cells no longer secrete insulin. Insulin is needed to absorb glucose, and the lack is often due to autoimmune destruction or when the body becomes resistant to insulin. Resistance can occur due to genetic or environmental causes. The higher levels of glucose in turn impair pancreatic beta cell function, worsening the insulin resistance. When glucose moving into cells is impaired, adipose tissue releases free fatty acids. These fatty acids are taken up at the liver and then turned into oxidative fuel via acetone, acetoacetate, and beta-hydroxybutyrate. The more abundant keto acids, acetoacetate, and beta-hydroxybutyrate build up, and when there is greater than 3 millimoles per liter, we get metabolic acidosis. Acetone is not a keto acid, but gives the fruity odor to the breath. Our patients aren't drunk, but it might smell that way from their breath. Patients may have polyuria, polydipsia, weight loss, just like George. They may also show some hyperventilation and abdominal pain. It is important to compare this condition with hyperglycemic hyperosmolar state, another condition of hyperglycemia. But this one can show more neurological symptoms, such as lethargy, focal signs, obtundation, or coma. The clinical features of DKA, according to the American Diabetes Association, show a blood glucose level greater than 250 milligrams per deciliter, plasma bicarbonate less than 18 milliequivalents per liter, and plasma pH less than or equal to 7.3. There is an increased anion gap and evidence of ketones in the blood or urine. Exceptions to this are in 20% of cases. Blood glucose is less than 250 milligrams per deciliter, or there may be a normal anion gap. This is due to the renal excretion of ketones, accompanied by an increase in chloride reabsorption. So the increase in chloride increases the anion gap. We may also see leukocytosis. This is not a reliable indication of infection in DKA, since the ketonemia produces leukocytosis. What is a reliable marker of infection during DKA is an increase in immature neutrophils, the bands. Better to look at this to know if our patient really has an infection going on. You may recall some other reasons for high anion gap metabolic acidosis are mud piles. Other causes of high anion gap metabolic acidosis include methanol, uremia, alcoholic ketoacidosis, starvation ketoacidosis, paracetamol or acetaminophen, propylene glycol, paraaldehyde, infection, iron, iron acid, lactic acidosis, ethylene glycol, ethanol, salicylates, or aspirin. Clinical features of DKA almost always include dehydration, but the plasma sodium does not reflect this because the hyperglycemia draws water from the intracellular fluid. There is a dilutional decrease of serum sodium masking free water loss. Dilution due to hyperglycemia results in a decrease of serum sodium 1.6 to 2.4 milliequivalents for every 100 milligrams per deciliter, increase in serum glucose concentration. Now, in DKA, 27% of patients will have elevated troponins without any acute coronary event. However, patients may be having a myocardial infarction as an instigator for entering DKA, so we still want to pay attention and do our due diligence to rule out an MI. As well, you may see hyperamylasemia. This is common in DKA, but the amylase is extrapancreatic and does not suggest pancreatitis. To diagnose DKA, we want to look at the labs, electrolytes, as well as a calculated anion gap and arterial blood gas. The serum electrolytes will show an elevated anion gap, elevated glucose, elevated potassium, and decreased bicarbonate. The arterial blood gas will show a pH less than 7.3. To confirm the diagnosis, serum and urine ketones, beta-hydroxybutyrate and acetoacetate, should be present. Other examinations we may want to include are a CBC, UA, urine culture, chest x-ray, and blood cultures. It makes a difference in what setting you are treating DKA. If you are in a hospital, you may have an automated system that helps you supply the patient with the appropriate amount of insulin. At my hospital, we use Glucomander. And because the patient will be needing an insulin drip, they will be sent to the ICU. Now, if you are out in the boonies or perhaps at an urgent care, you may need to treat DKA manually. Let's talk about that now. Something to keep in mind is the reason for the patient and their DKA. I want you to remember the 5 I's. Infection, such as a UTI, insulin deficiency, ischemia, such as a myocardial infarction, inflammation with elevated lipase, or incubation. Perhaps your patient is pregnant. We will be measuring serum glucose every hour and basic electrolytes and venous pH or bicarbonate every 2 to 4 hours until the patient is stable. When treating the patient, it is important to think about both the extracellular fluid volume and the free water deficit. If our patient is in DKA, they have been peeing out a lot of sugar, and with that, a lot of water has gone with it, and our patient will be dehydrated. If there are signs of shock, several liters of IV isotonic 0.9% saline should be administered. If there are no signs of shock, 15 to 20 milliliters per kilogram per hour. So this is about 1 to 1.5 liters per hour for an average size adult. If there are no cardiac concerns, and this should be for the first few hours. After the intravascular volume has been restored, we can give half isotonic saline, 0.45%, at 4 to 14 milliliters per kilogram per hour. If the corrected serum sodium is normal, or if the corrected sodium is reduced, we want to administer isotonic saline. For the insulin regimen, there are several modalities that we can use. Initially, we want to start with an IV bolus of 0.15 units per kilogram of insulin. Thereafter, the insulin should be 0.1 units per kilogram per hour. An alternative therapy would be no bolus, just 0.14 units per kilogram per hour of insulin. When initiating insulin treatment, we want to be cautious that the patient is not hypokalemic. Because of the pathophysiology of diabetes, the potassium has been pushed out of all the cells, and if the potassium is low prior to starting insulin, you know the potassium will drop even further as it starts to enter cells and leave the interstitial space. This would be bad as it could cause a heart arrhythmia. We want to replete the potassium and fluids prior to starting insulin if this is the case. We will continue treatment with insulin until the ketoacidosis has resolved. And if the patient has been started on oral intake, they're likely pretty hungry as they probably didn't get much to eat since being here in the hospital. At this point, we can transition to subcutaneous insulin. If the patient is staying in the ICU, we do not need to achieve euglycemia because there is a risk of hypoglycemia. We just want the patient to be at 150 to 200 milligrams per deciliter. If the serum glucose does not fall at least 50 to 70 milligrams per deciliter in the first hour, double the amount of insulin infusion. When treating the potassium, it is usually low, even though it is shown as a normal serum potassium. In the setting of a DKA presentation, the potassium can fall quickly, so we need to replace it quickly. We should be monitoring the potassium every 1 to 2 hours until the level stabilizes. When the initial serum potassium is less than 3.3 milliequivalents per liter, we hold the insulin and give 40 milliequivalents of potassium every hour until the serum potassium starts to increase. If the initial serum potassium is 3.3 to 4.9 milliequivalents per liter, we add 20 to 30 milliequivalents of potassium to each liter of IV fluid to keep the serum potassium at 4 to 5 milliequivalents. If the initial serum potassium is greater than 5 milliequivalents per liter, we will check the serum potassium every 2 hours. And if greater than 5.3, we do not give any potassium. We will delay potassium chloride until the potassium has fallen to 5 to 5.2 milliequivalents per liter. Now, how do we know our patient has exited ketoacidosis? Resolution should show a glucose less than 200 milligrams per deciliter. The plasma bicarbonate will be greater than or equal to 18 milliequivalents per liter. And the venous pH will be greater than 7.3. Remember, we were checking the blood about every 2 hours. If the patient has a pre-hospital regimen of insulin, we want to use that. For an insulin-naive patient, we will start at 0.5 to 0.8 units per kilogram per day in divided doses. We will continue insulin infusions a few hours after the first subcutaneous dose. Knowing how much insulin the patient needed to be stable at a stable blood glucose level can also help guide our insulin prescribing for this new patient. The bicarbonate and pH are unreliable when using isotonic saline, that's 0.9%, because of the high chloride concentration in isotonic saline causing a hyperchloremic metabolic acidosis. The anion gap is a more reliable measurement for resolution from DKA. When we follow up with our patients, our goal A1C will be less than 7%, and we should be monitoring this every 3 to 6 months, sometimes more frequently to begin with. Our blood pressure goal should be less than 130 systolic. The patient should be on a statin with annual lipid monitoring. Every year, the patient should have a dilated eye exam and a foot exam as well as urinalysis to check for microalbumin. If microalbumin is found in the urine, we should be using an ACE inhibitor or ARB for renal protection. As well, we should encourage annual influenza vaccination and a one-time pneumococcal vaccine. We will repeat this if the first dose of pneumococcal vaccine was given at less than 65 years of age and done more than 5 years ago. Wow, that was a whirlwind just to save George. He was in a pretty critical state there for a while. Thanks for coming along the ride with us. George will have quite a few life changes now that he has a new diagnosis of diabetes. While he does have a family history, it was a bit of a shock to him that he developed diabetes. He just never thought that it could happen to him. He will be on medication likely for the rest of his life, and he's going to have to be conscientious about making some lifestyle changes when it comes to making wise choices in the kitchen and being active. I know George can do it thanks to having a supportive team around him for encouragement just like you. Thank you for joining us today, my healthcare team. I hope you will join us next time to see what George gets up to next. Bye-bye.